Well, good morning, good afternoon, good evening, everybody. My name is Dion Filmer. I'm the director of the World Bank's Development Research Group. And welcome to today's, which is the May edition of our Policy Research Talk series. I'd like to welcome our in-person audience as well as our online audience, both on WebEx as well as on YouTube. For those in the room, we've been asked to please keep masks on unless speaking, and the whole room is set up for social distancing, so we're complying with all the rules and guidelines. These policy research talks provide us with an opportunity to present work coming out of the research department here at the World Bank, with the goal of sharing findings inside and outside the department, along with others outside the bank. Today's policy research talk is a special occasion because we're using it as an opportunity to launch our new policy research report, improving effective coverage in health. Do financial incentives work? The policy research reports are a product of the Development Research Group that have the aim of synthesizing the most rigorous evidence available from within and beyond the bank on important topics in development. The reports benefit from our department's dual mandate of working closely with bank operations on projects while also producing cutting-edge research on development. This particular report takes on an issue that's especially relevant in many low-income contexts. It looks at the evidence on the impact of financial incentives in health over 15 years and nearly 40 countries. Two of the lead authors, Damien Walque and Eeshani Kandpal, will be co-presenting today. Damien is a lead economist in our human development team, and his work is currently focused on the impact of financial incentives on health and education outcomes. Eeshani is a senior economist in our poverty and inequality team and conducts research on financial incentives like cash transfers to poor households and pay-for-performance contracts with health workers. We're grateful to have Norbert Schady and Feng Zhao as discussants today. Norbert is Chief Economist for Human Development at the World Bank Group. He's published extensively in academic journals, and his main research topic areas include early childhood development, teacher quality, cash transfer programs, and the effect of economic contractions on the accumulation of human capital. Feng is the Strategy, Operations, and Global Engagement Practice Manager here at the World Bank. As World Bank Practice Manager, he oversees the bank Global Health Engagement Program and has more than 20 years of experience in public health, medicine, economics, and demography. I'll ask Damien and Eeshani to speak for about 40 minutes, after which we'll hear from Norbert and Feng for approximately 5 to 10 minutes each. We'll conclude the session with questions and answers from the in-person and online audiences. If you have a question in person, we'll ask you to come to the microphone at the start of the Q&A. If you're watching online and have a question, please use the raised hand option in WebEx and I will call on you. If you're following on YouTube, please submit your question in the chat and that'll get relayed to us. Just a reminder, we are recording the session, and if you're following online, please do mute your microphone unless you're speaking. So with that, over to you, Damien and Eeshani. Thank you.
Thank you very much, Dion, for these kind words, and thank you for all of you for coming today in person or following on WebEx on YouTube. So it's a pleasure for Eeshani and myself to present you this report, this policy research report entitled Improving Effective Coverage in Health, Do Financial Incentives Work? So I'd like to start by saying this is the work of a large team composed of colleagues in the research department at the World Bank, as well as in the health, nutrition, and population global practice at the World Bank. In addition to Eeshani and myself, the team includes Adam Wagstaff, Jet Friedman, Sven Nielsen, Moritz Piatti-Fumskirchen, Anja Soutman, Gil Shapira, and Ellen van der Poel. And recently we took this team picture outside of the bank, but since Ellen is sitting in Dakar, we had to Photoshop her in the picture. We also want to take this opportunity to dedicate this report to the memory and legacy of Adam Wagstaff. He was the driving force behind this report. He contributed numerous concepts and analyses. And as many know, he untimely passed away 2 years ago. He still remains an inspiration for us, but we are missing him. So now I want to start with the big picture that motivates this report. And this big picture, we call it a frustrating status quo. So we are going to illustrate this frustrating status quo with the example of pregnancies. And what we see around the world is that pretty much everywhere, there are high rates of antenatal care visits around the world. That is, most women who are pregnant see at least once a service provider, they have an antenatal care check. On this map, you see that the dark blue is more than 90%, the countries where more than 90% of women have an antenatal care check. It's a lot of countries, and the other countries are also in this darker shade of blue above 80% or 70%. But despite that, what we see is that at the same time that there is widespread access to antenatal care, we still find high maternal mortality rates in many low-income countries. So this is, on this map, you see maternal deaths per 100,000 live births. The dark blues are countries where maternal death is very low, and the colors that are orange or red show you countries which are mainly known in West Africa or Central Africa, but also in Afghanistan, where we still have shockingly and stubbornly high maternal mortality rates. And this is true not only for maternal health, but for a lot of other health outcomes. Indeed, the Lancet Commission on High Quality Systems conclude that most deaths in low-income countries are due to the poor quality of care rather than the lack of access to care. There are still important gaps in equity in access to care, and a lot of primary health care systems are still very fragile. And so now, as we are hopefully coming out of this pandemic, and if we think about, regaining the gains that occurred before the pandemic, we know there's been further decline, or there's been decline during the pandemic. And as we want also to go beyond the gains that we had before the pandemic, we think we really need to focus on quality of care. So that's the motivation for this report. And if we think about quality of care, one problem that as economists will call the principal agent problem is present in health, but also it's common in many markets, especially in the public sector. What is the principal agent problem? Is that you have an employer, in the case of health would be the Ministry of Health, for example, who does not observe the performance of or effort by the worker. In the example of health would be doctors or nurses, or in schools it would be teachers, and that can lead to shirking by the worker or lack of effort. But at the same time, the employer can observe the outcome, but that outcome is not determined entirely by the effort of the worker. We know that health outcome, even with good treatment, can go bad. So that's the main issue of the principal agent problem. Faced with this problem, one solution has been performance pay. So paying for performance is very common to deal with the principal agent problem, and it basically links prices to actions. It's used across many public sector bureaucracies with applications in education, infrastructure, agriculture, public-private partnership, contracting with nonprofit, and in health, and we are going to focus on the application in health today. The goal of this approach is to improve the efficiency of public expenditure. And as I said, performance pay is based on the quantity and the quality of service delivered. And we'll give some example. And we want to stress that the introduction of performance pay was a paradigmatic shift from input-based financing, which was basically the status quo before, towards more transparency and accountability. Health is one example, an important one, but there's a big push across sectors for donor as well as domestic resources to be shifted towards a performance pay mechanism. So what we are going to look in this report is that performance pay and performance-based financing, abbreviated by the acronym PBF, projects in health. And let me first stress that PBF project, performance-based project and performance pay are not one and the same. PBF are projects that actually deploy a package intervention, and that includes performance pay indeed, and that's one admittedly crucial component of PBF package, but also other components in that package, more autonomy for the frontline health facilities. They can decide more about how they use their own budget, etc., more transparency and accountability, and more community engagement. And these are all also related to substantial effects on the financial management of the health system. So these reforms, these performance-based financing packages have been supported by a very large trust fund managed by the World Bank called the Health Result Innovation Trust Fund. It was mainly invested in performance-based financing approaches for maternal and child healthcare in low-income countries. It spans 15 years and 40 countries, and one very strong element of that trust fund is that it not only supported many projects, but also many rigorous impact evaluation. And we are building on the evidence from these rigorous impact evaluations to produce this report. It was also the opportunity for a sustained and fruitful collaboration between the research department here at the World Bank and the teams in the health sector at the World Bank. So what have we learned from these pilots? That's what we are going to try to answer today. So, and you know, I could, and I've used that picture before. You all know this glass of water, and if you're an optimist, it's half full, and if you're a pessimist, it's half empty. And when you have an impact evaluation, you have some significant outcome, positive and significant outcomes for some of your results, but some other outcomes you were expecting some result and you don't find them, and you conclude mixed results. And then you show this picture. But what we want to do today is go beyond that. We want to go beyond that cliche of the glass half full and half empty, and let you pick and decide whether you are optimist or pessimist. So more specifically, we want to look at the content of our findings. And what we are going to do in this report is look at these 5 questions. First, what does the evidence say about performance pay in low-income country health system? We're going to assess the impacts on coverage and effective coverage. I will give you a more precise definition of what we mean by effective coverage, but basically think of it as health coverage with a minimum content and quality. And we are going to look at this for maternal and child health services. Second question is, what are the key constraints to quality? Which constraint to quality can be addressed by performance pay? And can we realistically expect performance pay, to improve quality? And if yes, by how much? Third question, can demand-side approaches improve coverage and effective coverage of maternal and child health services? PBF, performance-based financing, is a supply-side approach, but we can also act on the demand side, and we should also look at that. Fourth question is, how do this performance-based financing project compared to what we will call, and define shortly, direct facility financing, abbreviated by DFF. And finally, what are the key lessons that we can learn from this evidence for the design of new health financing reforms? Briefly, giving you the snapshot of the geographic scope of the report. As you can see, it's quite broad, even though for some of the section we are going to focus on a set of countries in sub-Saharan Africa. So let me go back to this distinction between performance-based financing, PBF, and direct facility financing, DFF. And on the left, you have the 4 components of PBF that I've already covered: performance pay, operating budgets and autonomy, transparency and accountability, and community engagement. Well, if you want to know what is DFF, it's basically the same with the exception of performance pay. There is no mechanism tying the payment of the health facility and the health worker to the quantities and quality delivered, but the 3 other components are there. With this in mind, let me give you a sneak peek at our key takeaways. The first one is that overall, we find little evidence for impacts for across-the-board performance pay in under-resourced and unfinanced health systems. Instead, we find that direct facility financing that I just defined, with autonomy and accountability at the level of the frontline facilities, can deliver many gains at lower cost and with relatively easier implementation. So what we suggest is that for teams working in health reform, is that before designing health financing reform, they should do an assessment in 3 steps. First, assess coverage versus effective coverage for their indicator of interest to identify where would lie the low-hanging fruit for performance pay. Second, assess the constraint to quality of care that would ensure that they are in the locus of control of the frontline worker, that is, the frontline worker can actually act on these barriers. Third, they should find that sweet spot where baseline utilization should have some room for improvement, but not be so low as to indicate that there are demand-side barriers. Because when there are demand-side barriers, it would be best to include demand-side approach, and so we suggest often that it can be useful to combine demand and supply-side approaches. And finally, we suggest also to sequence intervention and use performance pay strategically. So now I'll come back to this concept of effective coverage and try to motivate it and also give you a more complete definition. So what is effective coverage? It is health coverage that includes a minimum content and quality of care. And you can think of it as the product of coverage and quality. We've tried to show that in that very simple equation, where effective coverage is basically the product of coverage, that is the percentage of person in need of care for a specific medical condition X, who actually consult, that's coverage, times the percentage of people consulting who get relevant care. In the report, we operationalize effective coverage by investigating how to measure it using existing data. What we do is use household survey for 93 countries, and we show how effective coverage varies by country, by wealth level of the patient, and also across different medical conditions. We want to stress also that when we look at quality of care, we not only looked at insufficient care, whether not enough is done, but also at irrelevant care or overuse, when something is done that should not be done. Either it's waste or even it can be harmful. So we look at both issues when we look at quality. Let me give you one example, one illustration of effective coverage using the example of antenatal care. In this figure, on the horizontal axis, you have coverage going from 0 to 100, and it's defined as the percent of women giving birth who had at least one antenatal care visit. On the vertical axis, we have quality of care, also going between 0 and 100, and that's among these women who got at least one antenatal care visit, the percentage who had correct treatment according to WHO guidelines, which is defined as the percentage who had at least 4 visits, one of these visits with a skilled provider, and for whom blood pressure was taken and blood and urine samples were taken. So then we can draw what we call effective contours, line of effective coverage, and they are here for illustrative purpose, but they are basically lines that show different points of coverage and quality that gives you the same effective coverage. Okay, so let's look at 6 countries, 5, sorry, in Africa to see what the data tells us. If we look at the Republic of Congo, we see high level of coverage, above 90%, and fairly high level of qualities, around 80%, that gives us something around 70 of effective coverage. Now, if we look at the 2 next countries, Cameroon and Nigeria, coverage is somewhat lower, between 70 and 85%, but quality is also markedly lower. It's around 60%, and that brings us to a lower level of effective coverage. And then the next 2 countries, the Democratic Republic of Congo and the Central African Republic, if you look at it, they have similar levels of coverage compared to Cameroon and Nigeria, but their level of quality is much lower, it's below 40%. And as a result, we see that effective coverage is basically under 30. So with that illustration, I'll give the floor to Eeshani, who is going to go more in detail into the quality of maternal and child health.
Thank you. So as Damien sort of motivated, there's this gap between the coverage of maternal and child health services and the quality or the effective coverage, pointing to serious problems with quality in many of the contexts that we're going to be talking about later today. So what we do is to try and understand, how you improve quality. As a first step, we try to understand what the constraints to quality are. In other words, why the rate of relevant treatment is not 100%. The literature often points to health worker effort, or the lack thereof, as the binding constraint to quality in these sorts of settings. If this is true, that health workers are sort of leaving money on the table by not doing everything they could do, and crucially, if effort is observable and it's contractable, then performance pay might make sense. Performance pay to the health worker might in fact improve their effort. But is that the case? In fact, if we think about it and we sort of systematically decompose quality, what we find is that the constraints to quality actually may lie at several different levels. The first is that of the health facility, or perhaps at a higher level, in the form of problems with equipment availability, drug availability, availability of supplies. Now, you might say this should be in the locus of control of the health facility, but note that in centralized systems, you often have to go through centralized procurement to address these sorts of issues. So this might not even be in the locus of control of the facility, leave alone the health worker. It might lie further upstream in the medical system in the form of medical training, problematic medical training. So, that's it with medical schools. And there's typically a centralized syllabus of what's taught and how it's taught. There's, of course, issues of the public expenditure tracking system, which can lead to, if there are significant delays in salaries being disbursed, problems of worker absenteeism. So if workers don't even show up at the health facility. Then, of course, there is health worker effort, which is the component that is malleable to performance pay that's given to the health worker, right? And then finally, there's potentially patient-driven demand, which may combine or may not combine with the worker's effort, but likely depends on the patient's socioeconomic status. And we'll touch upon all of these aspects at various points today, but the main message I want you to take away from this is that not all of the constraints are in fact controlled by frontline facilities or workers. And so there may be important limits at the very outset to what performance pay that's designed to go to the health worker to improve their effort could even achieve in these sorts of settings where there are competing constraints. So to formalize our thinking, what we do is use the no can do gap framework to decompose constraints to quality into the following three gaps. The first is structural capacity gaps, which tell us about what's available at the health facility and for which we need data on health facility infrastructure, so equipment, drugs, and supplies. We need knowledge gaps. To assess knowledge gaps, we need data assessing health workers' knowledge of clinical protocol for the types of care that we're interested in studying. For this, we typically use vignettes with health workers. And then we can put these things together once we have direct observations of patient-provider interactions to assess underused capacity, sometimes also called no-can-do gaps, which is care that could have been provided but is not. And this is, again, the component of care that is malleable or amenable to performance pay directed to the health worker. This is a data-intensive exercise, as you can see, but we can quantify these gaps for antenatal care consultations in 5 sub-Saharan African countries, which are Cameroon, the Central African Republic, the Democratic Republic of Congo, Nigeria, and the Republic of Congo. Using this large HRITF impact evaluation portfolio that Damien has described, we can leverage really rich data, sort of uniquely rich data on the patient, on the provider, and on the facility, characteristics of all of these three things, as well as patient-provider interactions. And what we do to benchmark the quality of care, to say that this is what should have been done, is use the WHO protocol for antenatal care. And I'll talk about that in a little bit more detail on the next slide. But one other thing I want to note is that we assess 2 different manifestations of poor quality. The first is underperformance, which is where the health worker does only a share of what she should be doing in a patient-provider consultation for antenatal care. The second is overtreatment or irrelevant care that should not be provided. There are 2 interesting things to note here. The first is that these coexist. So at the same time, health workers aren't doing everything that they're supposed to be doing, and they're doing things that they're not supposed to be doing. And the other thing is that some of the measures of irrelevant care, which I'm really not going to have time to talk about today, but you can read about in the report, are actually harmful to the growing fetus, and they're still being done in these settings. Okay. So the first key finding that I want to show you here is that structural capacity gaps, knowledge gaps, and underused capacity coexist in these antenatal care consultations in all 5 of the countries that we examine. On your left here is a snapshot of the essential equipment, drugs, and supplies that are needed to perform that antenatal care visit as per protocol. So on the y-axis, you have the some of the physical infrastructure that's required, and on the x-axis is the percent of facilities that had this item in stock and correctly stored on the day of the survey. And the main thing to note here is that, these are facilities, frontline facilities that are supposed to and do, in fact, provide antenatal care on a routine basis. And yet, even for these basic elements of care, elements of infrastructure, there's far from universal availability. And you can, look at the report for the full set of structural capacity gaps. On the right here is where we put things together. I'm not going to go into knowledge gaps, but you can, again, look at the report to see how knowledge gaps do exist for every aspect of care. But putting it all together on the right here is underused capacity. And what we find here, again, for just a snapshot of the actions, but in the report, we report underused capacity for all 16 actions on the WHO protocol. The first thing to note is that, yes, there is underused capacity for every single aspect of care, for every single task that should be performed by the provider. That said, the highest level of underused capacity anywhere is actually for counseling, for which you really don't need any infrastructure. And there, we have an average underused capacity of 50%. But overall, underused capacity only explains 1/3 of observed underperformance, which is to say that 2/3 of poor quality are not actually attributable to poor worker effort. So there are many competing constraints in these settings, and performance pay is therefore unlikely to be a silver bullet in isolation. We also find that wealthier women are 3 times as likely to receive high quality care as poorer women. Part of this is driven by facility choice, and so there's lots of within country variation in facility quality, and so shoring up the worst facilities within a country is likely a worthy investment. But we also have some evidence of within facility inequality, which is consistent with, although not the same thing as, discrimination by the provider, but that we do see that, which may point to the role of user fees and patient information and interventions designed to address these issues there. But to summarize, what I want to leave you with for this section of the report is that health system financing does appear to be a central challenge, but it has to address still, despite decades of sustained investments, gaps in structural capacity, in medical training, and at the same time, worker effort. So to do so, to design sort of a robust health system financing reform, we suggest doing things like tracking coverage versus effective coverage ex ante. And you can use, as Damien showed, available household surveys to do this. To also assess the constraints to quality before, along these lines, this sort of a decomposition, before designing interventions that aim to improve quality. So let's look at what sorts of interventions have been designed to improve effective coverage. So the literature in performance pay is quite well established in the health sector with evidence from high-income countries. These performance pay interventions, which include the US's Medicaid system and the United Kingdom's national health system, focus on clinical quality. These are high-quality systems that have few other competing constraints other than worker effort that the performance pay is attempting to address. These are decentralized, well-resourced systems. Even so, the literature is at best sort of mixed in terms of impacts of performance pay, particularly on clinical quality. Furthermore, what we're going to be talking about today are applications in a very different type of setting. So low-income settings typically tend to be centralized. They don't have operating budgets to facilities. There's no autonomy over facility management and staffing. And the incentives, as Damien has described, in these performance-based financing programs pair incentives to the facility for structural improvements, because that's a known constraint that was also attempted to be addressed with these interventions, and at the same time, worker incentives, performance pay to the worker. The early evidence of PBF projects from these settings, from Rwanda and Burundi in particular, was quite promising. Interesting, I'm getting an error message here. Okay, there we go. So in terms of the key features of the PBF projects, as Damien described, there are four. Let me just give you a concrete example of how that performance pay works. So this is an example for Nigeria. So it paid $12 for every woman who gave birth in a health center, $1.20 for an antenatal care visit, and 80 cents for child immunization. It also provided unconditional financing for everything but staff remuneration to the facility and gave the facilities autonomy over how to spend that. Facilities could then report performance on these purchased services, typically every month, and then payments were based on these reports. In addition, there was a third-party audit, typically every quarter, of these reports. And this is expensive to implement because you need the auditor to go to every frontline facility. So, for example, in Nigeria, 1,100 facilities participated in only the pilot. And so, at scale, that's many, many more facilities. That's expensive. That adds up. But it also creates an opportunity for gaming or collusion. And finally, there's a community engagement component wherein ward or village development committees sometimes attend the facility management meetings. The scope of evidence that we're going to focus on largely is from sub-Saharan Africa for this component. And these are by and large the first generation of PBF projects that use this sort of price checklist that I just gave you an example of. But we do spotlight evidence from high and middle income countries and later stage PBF designs that I'll come to towards the end of my time today that use other approaches or a combination of approaches to improve quality. And again, we're mostly going to focus on maternal and child health, but we do also touch upon curative care and non-communicable diseases with the hope of answering the question, what is it that we learn from these donor-financed pilots about at-scale health financing reform that would use domestic resources? To answer this, the first comparison we are going to look at is PBF versus business as usual. I'm not really going to go into the coverage impacts of PBF projects, but the recent Cochrane review by Sophie Witter and others finds that at least in most contexts, there are some improvements in terms of simple coverage, although there is a lot of heterogeneity in the impacts here. In terms of quality, we're going to assess impacts on structural capacity and underused capacity going back to that no-can-do gap framework. So let me show you structural capacity first. But first, let me spend a second describing these types of graphs because I'm going to be showing you a few of these. So on the y-axis are the outcomes of interest. Above the dotted horizontal line are the summary indices. So here we're going to be looking at overall structural capacity, and then separately to understand issues of supply chain, we look at the drugs index. On the x-axis are the treatment impacts, here PBF versus business as usual. The dotted vertical line at 0 is 0 impacts. Increases or improvements, in this case in structural capacity, would lie to the right, and decreases obviously to the left. As you see here, overall, there are no, this is just an illustrative example from Cameroon and Nigeria, but again, go to the report, look at the Cochrane review for more detail on these sorts of impacts. But in general, we do find, at least on some aspects of quality, some positive impacts, sometimes fairly large positive impacts, even if overall there isn't. But then when we turn to underused capacity, the data for this are more limited. Again, this is a fairly data-intensive exercise, and we can only estimate these impacts for Cameroon and Nigeria again. But here, remember that underused capacity is undesirable. It's money left on the table. So increases are actually problematic, and yet that's what we find evidence of, looking at, again, all of the aspects of care that the WHO says are necessary, and really no overall reduction in underused capacity. The one other thing I want to note is that, yes, these are only 2 countries, but these are often viewed as 2 successful instances of the early stage PBF design. So despite that, no large impacts of performance pay. So the bottom line here is, performance pay in terms of quality is not a silver bullet for worker effort in these settings. And this is also consistent with limited evidence of impacts of performance pay on clinical quality, even with settings with fewer competing constraints. And if anything, the largest impacts we see are for structural quality, which may not be surprising given that that's where we saw a lot of the constraints up front to quality improvements, and only a third of underperformance being tied to underused capacity. But this then begs the question, are there more cost-effective ways of financing structural improvements? So let's turn to some other ways in which financial incentives have been leveraged for effective coverage. Here we're going to compare both coverage and effective coverage impacts of PBF projects to conditional cash transfers and voucher programs on the demand side, and direct facility financing on the supply side. And I just want to note that, as Damien's also said, these are not necessarily pure alternatives. They often can and should be used in combination, and the sequencing also becomes really important. Here's a geographic scope of the evidence for this part of the report. A lot of the PBF and DFF comparisons come from Sub-Saharan Africa, but by and large, we do have relatively wide global coverage. So turning to the comparison of PBF and demand-side alternatives, we draw on a meta-analysis that pulls evidence from 52 programs from 30 countries. And here on the right are the impacts summarized in this graph. So we look at PBF program impacts, voucher programs, and conditional cash transfer programs, and the mean effect sizes are on the y-axis for modern family planning and facility delivery, at least 4 antenatal care visits, and at least 1 postnatal care visit. In terms of effective coverage, we also look at maternal tetanus vaccination during antenatal care and full child vaccination. On average, it's true that all 3 types of financial incentives examined improve service coverage, and the mean effect sizes vary between sort of 2% and 7%. These are modest mean effect sizes, right? These are contexts where there's a lot of room for improvement, and by themselves, we're talking about fairly modest improvements from any of these. If anything, if you compare, for instance, the impacts of PBF to voucher and CCT programs for in-facility delivery here in the light blue, there may be some indications that CCTs and vouchers are actually more effective. Again, going back to sort of the constraints that are germane. The third and last set of comparisons that we look at is that of PBF and its supply side alternative, which is DFF. As Damien said, the only difference between these 2 is performance pay. However, the way in which transparency and accountability are operationalized in DFF projects is also a bit different. So in DFF projects, there isn't this reporting and auditing setup. There's just a business plan or a dashboard typically that facilities use. So this is a much lighter touch, less expensive, easier to implement without that risk of collusion and gaming approach for transparency. In the HRITF portfolio, there are 5 projects that directly compare PBF and DFF approaches, and we look at all of them. These are Cameroon, Nigeria, Rwanda, Zambia, and Zimbabwe, 3 of which, Cameroon, Nigeria, and Zimbabwe, also included a business as usual arm, so we can look at that comparison. And then in 2 of these, in Nigeria and Zambia, I just want you to keep in mind when I show you the results on the next slide, that PBF actually disbursed twice as much as DFF, so it's not actually a one-to-one comparison. That said, here's what we find. So on the y-axis, again, are all of the impacts of interest. And there are a lot of impacts here just to show you that we looked at a lot of different outcomes, right? We're not cherry picking here. And we look at outcomes related to effective coverage and then also simple coverage. The only place where we find an impact of PBF over DFF is for institutional deliveries. And even some of that, so these are, the significant impacts are the solid markers. Even there, some of the gain, although not all, not necessarily in some of the settings, but at least in a few of the countries, some of that gain is partially explained by a switch from the private sector to the public sector. It's being driven by an increase in institutional deliveries in the public sector, where we don't know the quality of the private sector. And so this is sort of unclear in terms of impacts on effective coverage. So just as I wrap up, a couple of other considerations and approaches in sort of strengthening program impacts and designing programs that might be more effective in terms of quality gains. One thing that we highlight both from the meta-analysis and a decomposition of effects in Nigeria is the role of baseline coverage in the catchment area. So if baseline coverage was really low, then that might be indicative of demand-side constraints for whatever reason and should be addressed through demand-side approaches. If it's very high, it probably means there's room for improvement. There's little room for improvement, and performance pay might not adequately reimburse the worker for the effort that's required. We also know from the high-income country literature, but also from an increasing number of examples from the HRITF portfolio, that performance pay, if anything, may work best at the hospital level, so not at the primary level. Again, a question of competing constraints. We know, for example, from one really sterling example in Afghanistan, that private sector contracting can be fruitful grounds for PBF. And that's not what we talk about here. We really focus on the public sector in the report, but this is an important thing to note. And then finally, we don't talk about cost effectiveness. There's limited evidence, and this is sort of a little bit outside our wheelhouse, but we do have aspects that we look at that are that have important implications for cost effectiveness. The first is that there are complementarities in tasks that might generate positive spillovers. The theory for this actually goes back to Holmstrom and Milgram, last year's economics Nobel laureates, but we don't see that theory being leveraged in the design of these performance pay contracts, and they perhaps should be. We also know from a large body of literature, including going to conditional cash transfers and even payment for ecosystem services, but also from this HRITF portfolio, that prices sometimes serve to signal the importance of the task you're purchasing. And so the level of the price might be less important than that signal. Also from the HRITF portfolio, we know the importance of using non-pecuniary tools to amplify the impact of the pecuniary ones, such as through the use of hands-on supervision, for example, through the anatomical mama-natally and neonatally models. I'm going to leave you with this bottom line for financial incentives, and that is that financial incentives, it is clear, improve service utilization and at least some measures of quality, but those impacts are small and they leave lots of room for improvement. In under-resourced centralized health systems, performance pay, we find, yields only modest additional impacts. But flexible operating budgets and associated accountability measures can deliver significant gains by themselves without performance pay, while avoiding the large additional costs and complexity of design of performance pay interventions. And with that, Damien's going to wrap up.
Thank you very much, Eeshani. And let me wrap up and try to focus on what could be the operational implication of these findings. So the key takeaways, we think, are the following. Overall, little evidence for impacts for across-the-board performance pay, especially in those under-resourced and unfinanced health systems. And we think that direct facility financing with autonomy and accountability, can deliver many gains at lower cost and with easier implementation. We note, for example, that performance pay make budgets unpredictable, both from the point of view of the government, as seen from the point of view of the health facility. And the costs related to verification in performance pay, which are necessary to enforce conditionality, can often be quite substantial. For example, in Nigeria, 2/3 of the project administrative costs were attributed to the effort for verification. So it's true that a risk-based system of verification could substantially reduce these costs, but still they remain important. In general, we find that performance pay is a complex intervention which, especially in those settings, can be difficult to scale. So now I'd like to finish with a few action items, and they don't necessarily come from the evidence. They are more like supported by the evidence. They are informed by what has been happening on the ground over the last 15 years, and that we have observed that we were working with our colleagues in the health sector in the design of this health financing reform. So our suggestion would be to start, if you think about starting a new health financing reform, to start by a set of assessments. First, assess, using existing data, coverage versus effective coverage to identify those low-hanging fruit for performance pay. Also, try to assess the gaps in structural capacity and in health worker knowledge, and try to measure what we've called the no-can-do gap, the difference between what is available at the health facility in terms of knowledge and equipment and what is actually done. And we think the sweet spot for performance pay is where baseline utilization has room for improvement. It's not too high, but it's not so low as to be indicative of demand-side barriers, which might best be addressed by demand-side intervention. And also, the sweet spot is also probably where there is a high level of no-can-do gap. So basically, there are underused capacity at the health facility. We also think that sequencing is key when you think about starting this new health financing reform. We suggest 18 to 24 months at the beginning after these assessments for demand-side interventions and direct facility financing, and then repeat the diagnostics exercise, and then introduce performance pay for select indicators. We also think that emerging technologies can reduce the implementation cost. We are thinking about mobile money that can send the funds directly to the health facility and the health workers. And in terms of accountability, there are new apps, etc., that can develop portals and dashboards to look at both quantity, quality, as well as payments. Let me finish with 5 key principles for sustainable health financing reform. Again, those are not necessarily new, but I think looking at the evidence from our report, it's important to highlight them again. The first one would be to send funds to the front line, to those health facilities serving people in the village and neighborhoods. Second one, ensure transparency and accountability through good facility financial management. Third one, when necessary, introduce routine supervision that should be supportive, not punitive. It's important also to introduce an output or performance orientation, but we note that this can be done through dashboards or portals and not necessarily or not always with just performance pay. And finally, it's important to unify the payment system as one system to push the payment to the front lines. With this, we're looking forward to the discussion, and thank you very much for your attention.
Thank you, Damien and Eeshani. So now we'll turn straight to our discussants. First up will be Norbert here, and then we have Feng, who is online. We'll go in that order, if that's okay. Thank you.
Thanks, Dion, and thanks, Damien and Eeshani, for asking me to comment on this. It's great to be back here. I've also read the report at great length, as more than once, actually, since I was one of the peer reviewers, and some of my comments are comments that I made at the time, and I want to reiterate some of them. So this is clearly a very serious research product in the best tradition of PRRs, I think. It brings together as much of the evidence as is available on the effectiveness of a particular kind of intervention, and then tries to make sense of this evidence sort of more broadly, not just the individual case studies. It's obviously highly policy relevant, so that's really important, and it's particularly policy relevant, I think, as we make the transition from sort of the focus on the pandemic to sort of the more underlying, if you want, routine problems that health systems face in many of the countries that we work on. I sat in during the spring meetings at many of the conversations we had with ministers of finance and ministers of health and education and so on. Certainly in the conversations on health in sub-Saharan African countries, there was often a feeling that we as the bank were perhaps too concerned with things related to the pandemic and not concerned enough with some of the underlying health issues that these countries face. So I think this is really an important report in that regard as well. I think there's so much that is useful in this report, so I'm going to just highlight a few things. And this list is by no means meant to be the full list by any means. I think the descriptive results on effective coverage are extremely useful, the ones that are there for 150 some countries. I think of those kind of like what the WDR for education did with LAYS, showing that it's not just coverage that is important, but effective coverage. It doesn't make much sense to have coverage if people don't receive care that is useful in some ways, just as with education, it doesn't make much sense to have kids brought to school if they don't learn at least something. So I think that is really, really useful. I like these effective coverage contours that the authors present, which sort of make really clear the point that you can increase effective coverage either by increasing coverage or by increasing quality or some combination of the two. I will say that these contours are sort of, I mean, as the authors well know, this is not a point that they don't know, but they're silent on the fact that two different points on the same contour could have very different distributional implications. So you could basically, have coverage for a very small fraction of the population with very high quality, and you would be on the same point as having lower quality but broader coverage. So I think it's just something to keep in mind when we sort of make sense of these effective coverage contours. The results, to my mind, are quite sobering. The authors argue that PBF is no silver bullet. I know they want to get away from this glass half empty, glass half full analogy, and I understand. But on the other hand, for me, and I don't think it's only because I'm not the most optimistic person in the room, but I think it's hard, if you want, for me not to come away from this saying that it looks to me more like the glass half empty than the glass half full. I think we should take these results very seriously. I mean, we're all searching for solutions to really difficult development problems. And we really want things to work, and sometimes things that we think have to work and that really they have to work. Well, maybe they don't work, and maybe we get carried away by our enthusiasm somewhat. I also like the fact that in the report, I very much like the no can do framework. Jokingly, I said when I first started telling somebody else about this, they thought I was saying no can do, like no can do. And maybe that is one of the messages, no can do this stuff. I mean, really it's too complicated, no can do. But no, on a more serious level, I think it's really useful to try to identify where the constraints are to having more effective coverage. And I think what the authors point out that many of the problems and potential solutions are things that don't depend really on health worker effort, that they're not really in the locus of control of that particular health worker. They don't have the right materials or infrastructure in the health center, or the training and education that they received wasn't adequate. And so these are things that are not going to be solved by trying to incentivize more effort. And the authors, they don't cover it here, but they go in some length in the report about, I mean, this the staggering levels of coverage or treatment that is ineffective and potentially harmful. I mean, these are huge numbers. I had no idea, and surely that shows just my ignorance. But if that is my ignorance, it probably isn't ignorance shared by many others. But the levels are really, really big, and the fact that in some cases the performance-based financing makes this worse is definitely a source of concerns. Can you guys put up slide 41 for a second? Because now comes the part of where I sort of like wonder a little bit about some of the conclusions that we draw, only if it's possible. So that's slide 41. So I think this is a really important slide, because really at the end, what the authors conclude is that direct frontline financing, DFF, can have the same effects as PBF, and in some sense that maybe this is what we should be doing instead of PBF. But really what I see there is that DFF had no impacts either relative to business as usual. So here again, you look at the coefficients, if you want to look at, which ones are the DFF versus none. So those are the little squares, blue squares, and I see as many just about negative as positive and no significant results. So it's hard for me to conclude from this. I mean, I understand here we are in the glass half empty, glass half full, and we're saying, well, PBF is a problem. It's too complicated. It may give us the wrong incentives, but I don't see much evidence here that, at least in these countries, the DFF, so this direct transfer of resources to the frontline workers with accountability and so on, that this actually improved outcomes. It seems to me that it's a bit speculative to say that it improved outcomes, unless we're somehow thinking that, as this thing gets institutionalized, if you want, sort of over time, people get used to it and this improves outcomes. But here in this figure, I don't really see any evidence of improved outcomes either from PBF or from DFF. And I think we want to be honest with ourselves about that as well. Couple more points. The authors point out that the early results from PBF from Rwanda and Burundi were encouraging. And that's really interesting to me. So why were those encouraging and the rest not? I mean, I don't know the answer, and maybe somebody else knows the answer, but it seems like, again, because we saw those as encouraging, we sort of went in, fully into this approach and were then disappointed. So some reflection about why those were encouraging and the rest were not, I think would be really useful. These are based, I'm reflecting now on the presentation more than on the report, but I think that would be useful. A few sort of qualifications. I think the authors well acknowledge that the focus is mainly on maternal and child health, and it's just something to keep in mind that we're talking of maternal and child health, not lots of other things in health. We're also not talking directly of health outcomes. We're talking about the use and the quality of these services. I think all of us have some doubts about how directly the outcomes are linked to the use, so it's just, again, something to keep in mind. I don't find the comparison with CCTs, I've said this to the authors before, and it's fine, but I don't find the comparison with CCTs all that persuasive, because it really is a very different geographic sample. When we're looking at CCTs, the evidence is largely from middle-income countries, especially in Latin America, and the evidence from these PBF and DFF pilots is mainly from sub-Saharan Africa, mainly, I should say, at least the results that are stressed in the presentation. So I don't find that comparison as persuasive. But overall, I think this is really an important report. I think we all need to reflect in our different roles within the bank. We need to, in our conversations with policymakers, I think we all need to reflect on what messages we want to take away from this. I learned a ton reading it, and it leaves me with a lot of questions about where we should go next in these kinds of interventions. But thank you very much again to everybody for asking me to be a reviewer and then for providing comments. Thanks.
Thanks, Norbert, for those reflections. We will have a chance to go back to the team to maybe pick up on some of them. But right now, I'd like to turn to Feng, who's online, for his reactions and comments. Thank you.
Thanks, Dion. Can you hear me? Hello, Dia. Can you hear me and see me?
We can hear you very faintly. I don't know if it's on our side or your side.
Hello, is it better?
Okay, we can hear you in the room. Fine. So,
Okay, great.
perfect. Thank you.
Let me start. Very happy to be here. I first want to echo Norbert's point. This is, to me, a high impact report. It has a lot of policy implications, not only to this particular area, but also to our health program as a whole. So I really want to commend the team for getting this done and get the report in place. I would have hoped this report could have come much, much earlier, but nevertheless, it has brought a lot of policy thinking and policy reflections. So let me say that up front. This is also a topic very close to my heart. I'm actually on leave. I'm on my way to Michigan to accompany my kids for his sports. But when Mamtar asked me, I immediately said yes. Because when the RPF took off, I was a frontline TTL. I was based in Ethiopia. I can replay some of the conversation. I think it's relevant here. Let me just maybe put this as my first point. But before that, I want to say I'm very happy to see many colleagues have joined, and they are more qualified than me in these areas. I'm also eager to hear their comments during the Q&A time. The first question, the first reflection I want to put on the table is really, as I said, from a frontline TTL point of view. When I was based in Ethiopia, when this program sort of took off, we were very excited because we all tired about the stagnation of the poor health outcome, and we have been working on input-based financing for a while. We need something new, something exciting. When this came out, and together with a lot of analytical underpinning and case studies, it's not, there's no science behind it. So we were very excited, brought a lot of energy in our policy dialogue, and together with a lot of workshops taking place in Africa and our financing, there's a trust fund, large size of trust fund also behind it. But once we take on the policy dialogue with Minister of Health, Minister of Finance, and we run into a few, realistic issues. I remember the Minister of Health at that time was Dr. Tedros, now head of WHO, basically told us Ethiopia graduate 200 doctors per year. This is all we have. By directing your financing towards some health coverage targets will not resolve the fact that we don't have enough doctors. Right? So this is a constraint they are facing. So just give that one example. That maybe generate to one point I have. We know, money cannot resolve all the health issues. The solution often lie in a package of factors, sometimes beyond health sector. But because we are working on financing institution, inevitably we looking for solution toward that direction. So that's maybe the value of this report. Really got us thinking. I really like some of the conclusion of the report, and some of the message make me pause quite a bit to reflect. But nevertheless, I think this report has really hit the heart of our core sort of health program and make us think about what's going to work, how we can best help our clients. So that's one message I want to share. The second one is really on a forward-looking angle. So now the RBF or performance-based financing or some other terminology, the incentive we provide has evolved into a different phase. So we have an instrument called P4R. Many of this type of initiative has integrated into the overall health financing program. For example, many insurance agencies have quality-based measure, for them to contracting out services, and a lot of those performance financing element also embedded into that regard. So we are actually in a new phase. So that's why I want to encourage the team to think more in terms of the next step. I share Norbert's view. Let's go beyond the comparison between RPF, DDF, or CCT. There's many other options out there. I like some of the comments saying I will put a false dichotomy in there. To me, think about the instrument of P4R will be much more meaningful for our internal audience than compare with those different options. Sometimes the solution is really the package of them. It's not really one or another. The slide, the last slides were the second to the last slides on the sequencing. I question that. That also leading the philosophy of, have low-hanging fruit, have analytical work, but eventually land on performance pay. So maybe that's not the sequence we want to put forward. I know maybe you have different thinking, but I just question the sequence still working towards performance pay. This is something maybe we can think about it on the way forward. Recently, we have a conversation with OP. There's a lot of comments from colleagues from the HMP TTLs. One comment is the capacity building component, which is not the P4R, but is really a TA component to come together with, is so critical. Will help to address some of those bottlenecks and constraints in the system. The next point I want to put on the table is really about our decision making. And this morning in our HD forum, I think a few colleagues, Xiangnam, Trina, and Norbert, have put a session really on listen, learn for COVID. There's a lot of quick decisions have been made for COVID response without really solid evaluation or data or scientific evidence, but we have to make them, right? So to move forward. That sort of also related to this conversation, right? So the decision was made at the time, move forward, pushing for performance pay. But what's the science and evidence behind it at the time, and what's the evaluation which can help us make the adjustment? I want to challenge all of us. I hope that this study, if we done many years earlier, will really help everybody. This is nobody's fault. But I want to challenge two things. One is, have we learned from this? Do we have early investment on data, on science, on research, which will help us to make sound decisions in real time? That's the first one. Second, have we embedded evaluation quickly into our ongoing operations? In COVID, I appreciate IEG quickly put together some evaluation for our response, which have provided a lot of insights. But I hope we have done in many areas, like in this area. The next point I want to make is we shouldn't oversell the service coverage contribution to better health outcomes. We know health is complicated, it's multiple production function. Even you have perfect effective coverage, you have perfect quality, you probably still cannot get the desired health outcome. Let's be careful, because the social determinants, the other determinants of health outcome. So let's be mindful. I see some of the language there make me worried. So that's another point I want to make. Looking forward, I really want to encourage we all think about those issues. I do feel some of the strong elements, the principle Damien has laid out, I really like them. So financing to frontline, those, maybe by itself, even it's not necessarily lead to performance pay, will make a big difference. Maybe the solution will stop there. So that's why I question the sequence. Just I guess my point is let's be mindful about the package of service solution we put forward. Many colleagues have mentioned the silver bullet argument, but in reality, I see inevitably sometimes we bring solution before we see the reality. So that's just something I take home. I feel this is really the value of the report to reflect on those important issues. Let me stop here. I have more to say, but let me stop here. I want to hear from the audiences also.
Thanks, Fang, for those comments, both very specifically to this analysis and this report, but also some of the bigger challenges I think you're posing out for the HNP sector as a whole and probably even beyond. So we have about a little bit more than 10 minutes left. I propose a couple of people raised some questions in the chat that I don't think were necessarily answered. So I might call on just a couple of people who put in questions. Can I ask you to please keep your questions to sort of under a minute? And then we'll give the chance to the team to kind of respond both to the discussants and to these specific questions. And then if we have some time, we can do another round. So with that, I'd like to call in order, just to give you a bit of a heads up, on Adana, Emre, and Gyuri Fritsch. Can I call on you each in order to please unmute and ask a question? Again, keeping it as brief as possible, and then we'll turn it back to the team. So with that, Adana, are you able to unmute and ask a question? Oh, okay, Adana has left. So can we go to Emre? Is Emre still there?
I am. Just one moment, please.
Sure.
Sorry, I was in two meetings at the same time. Yeah, sorry. So my question was regarding, we're treating PBF as essentially unitary, that PBF is a single intervention. But of course, PBF is extremely different and looks very different depending on the setting. The level of the incentive is different, the methodology is different, the way payments are made can be different, it should be different. And even within a certain project, as it progresses year to year, typically we make methodological changes to adjust to how the incentives that we're trying to push are working. We'll increase amounts, we'll change incentives, etc. So, I mean, of course, it's by design, this type of analysis can't capture that. But I think it's worth noting that when we're comparing PBF, we're looking at different things. So I think this was answered a little bit in the chat already, saying that, well, the effect sizes aren't necessarily all that different. Though it did seem that there were fairly wide confidence intervals, but overall there aren't huge effect. But I think still the question shouldn't be PBF yes or no, but rather PBF, when, where, and how does it potentially work in complement with other interventions as well. And my experience on this is, at least the intimate experiences from one country in Cote d'Ivoire, where it worked quite well. And the country actually adopted it into their own national strategy and started using it as the way they reimburse at least part of facilities, and also integrated it with their social health insurance system. So because there were payment mechanisms set up, verification mechanisms set up, bank accounts set up, they said that they could actually use this to reimburse facilities for using social health insurance. So just to say, the externalities from this can be huge as well, and probably aren't, of course, can't be evaluated in a study like this, but are worth considering when we start to come up with hard conclusions as to, whether we should do PBF or not, or other things. Thank you.
Thank you. Gyuri, are you still there? And able to unmute?
Yes, I am. Can you hear me?
Sure. And just in the interest of time, could I ask you to be very brief? Sorry. Thank you. Go ahead.
Usually very brief. Good. I congratulate the authors of the report. I'm looking forward to read it. I know it's a lot of work in it. A couple of comments. One comment is I was always surprised about sort of this effort of trying to calculate the effect of performance pay on results. We know from the international literature that the way you pay doctors and nurses influences their behavior, right? So nothing new under the sun. One comment on the Nigeria experience, the PBF versus DFF. Actually, DFF is not a term used outside Nigeria. It's a Nigerian intervention. One comment on that intervention is that the impact evaluation showed that PBF, although it was twice as expensive as compared to DFF, saved more than twice as many years of life as DFF in the same period of time. I mean, the cost effectiveness was similar, right? The cost utility analysis was similar, but this means that basically you save more than twice as many years of life as compared to DFF. That doesn't come out of this mega analysis. Thank you.
Thank you. And before turning it back to the team, let me call on Oyebola, who's in the room here. Thank you.
Thank you. Great presentation. Just wanted to see if you had any frontline worker insights you could share with us about this no can do, because you're seeing that at the same time they're overdoing some things that are wrong and underdoing other things. So it doesn't seem like it's a time constraint. Just it's been really good to hear some frontline, like the conversation with the minister in Ethiopia and just hearing what people think is their own real constraints. And so it'd be great to have any anecdotal evidence, even you could share on that. Thank you.
Thanks. Damien, Eeshani, over to you.
Thanks a lot for all the comments. I don't know if we can address them all. Maybe one thing I'd like to start is follow up on Emre's comment, because I just want to emphasize what he says, and I hope we convey that message. This report is not about PBF, yes or no. It's precisely about when, where, and how, as Emre emphasized. So, I mean, I know sometimes it's easy to simplify, but we really hope to convey the message that there are times and indicators when PBF can be extremely useful. Oyebola, some anecdotal evidence. From my observation, when I've been in many health facilities, it's not I don't think the main constraint is time. So it's more like maybe a routine of not doing things or doing things. There is also an issue that we've not touched too much in this presentation, but it's in the report. It's sometimes some of the things that are done by health worker are not irrelevant, but they are demanded by the patient. So that's another issue, you know. Eeshani, you want to take the Nigeria questions?
Sure. I wanted to address a few things. One is to just remind people that this is a 290-page book, and there is, Norbert, even in your multiple readings, I think there's some of the answers to your questions, for example, on DFF impacts lie in the report. On, Fang's point about, just to push back a little bit on, why this didn't come up sooner, we have been presenting these results as they've come together. For instance, the pooled analysis, the meta-analysis, going back to the last HD week that was in person, so I believe the summer of 2019. And of course, we've worked with the country teams, as Damien described, for approximately 15 years now. Emre's point on the heterogeneity in PBF, there was also an excellent question raised in the chat about, by Reem, I think, on the importance of timely HMIS data. These are all things that we talk about in some depth in the report, so please do look at it. And Emre, also your point about the externalities of the system level, I think is really well taken. This is a thing that we acknowledge in the report that we can't really touch upon in the timeline of most impact evaluations, right? We're talking about perhaps decadal impacts on the health system. Oyebola, on your frontline anecdotes, there are many. There are some qualitative studies that I can point you to that are also cited in the report that bring together a wealth of evidence. But I think sometimes just in sort of economics terms, there is just inattention, right, by the agent. There's a lot going on. Jishnu's work shows how there's a complex interaction, I think, with facility infrastructure, with individual level incentives and intrinsic motivation. Ken Leonard's work shows this as well, as does Manoj Mohanan. So all things to keep in mind. And I do want to come back to Yuri's point about Nigeria and DFF. Yuri, I'll see your nothing new under the sun from Ecclesiastes and quote you, Pink Floyd. I feel a little bit like we've had this conversation many times and we're like two lost souls going around in a fishbowl at this point. As regards the impact on the lives saved, that depends on a particular assumption-driven estimation that we are not entirely comfortable with, I think, on this team, about the quality, that essentially is about the quality of public facilities, which is often unobserved. And when we have detailed data, as we do in this report, about the quality of public facilities, I think some of those assumptions seem quite heroic to us. And specifically for those who know the literature, we're talking about the LIST tool here. And so that's why we sort of stay away from some of that literature.
Thank you. We have 2 more minutes. I'm going to give Ben a chance to come in. Ben Levinson, he's had his hand up. Ben, do you want to come in with a brief question?
Sure. Just first of all, really a tour de force by the team. This is great, and one thing that would be really helpful is to see what are the lessons learned in terms of doing these impact evaluations. I think a lot of people will be skeptical, but from my perspective, it's been really valuable, and really helpful. I guess the real thing is that most of the work that we've done on PBF has been in the public sector, and so maybe it doesn't work so well in the public sector, but it could work quite differently in the private sector, which is why we see such differences in provider performance when those providers are private or are non-salaried civil servants. It'd be interesting to know what you think about this. Thanks.
We are out of time, so I do want to give you a chance to react to that private, if you have any thoughts on that private sector question.
This is a conversation that I think Benjamin and I've had before. I think the evidence is suggestive that both patients and providers react differently to the particular financial incentive structure at place in the private sector. And that's, I suppose I'll just end with, that's the topic for another report, another 290-page report.
No, but I guess we should just be upfront. It is mainly about the public sector, our report, and that's pretty evident.
Thank you. I do realize there's some people who had their hands up. There's some questions that I would have hoped to come to, but we have run out of time, and I do want to respect all your other obligations. So with that, let me thank the presenters today for a really interesting presentation of the highlights of the report. And as Eeshani mentioned, there's a lot more detail in the report, and I would encourage all of you to go and check it out. Also to recognize some of the members of the team in the room, and as well as the members of the team who couldn't make it here today. I think I saw a couple, well, definitely saw a couple of them online. Congratulations to all of them, and please join me in giving them a hand for this report. So, thank you, everyone.